It's exactly 2 minutes after 8. We're not going to be running a huge program as well. The Grand Rounds, welcome all of you to the 2026 Grand Rounds. This is the first meeting of the year. It's being hosted by the unit in Gqeberha, Livingston Tertiary Hospital. We decided on a trauma series. That's all we see. We run a community vascular service, and we don't do anything exotic besides trauma and bog standard PAD. So it only makes sense to speak about things that we know. Without wasting much time, I want to introduce a friend, a colleague, a gentleman that I trained with in my very formative years. His name is Willem Oosthuizen. Willem is an orthopedic surgeon with a special interest and certification in ankle and foot surgery as well. He also has a special interest in low velocity knee dislocations, and he's done a few studies relating to that. Willem, I just want to welcome you on. You can start and share your slides, please. So Willem is going to give us a talk on knee dislocations. I think it's something that we all encounter from time to time, and at times obviously has its own disastrous consequences given the challenges, BMI issues, and the availability of the saphenous conduit. Willem, you're welcome.
Thank you very much. Thanks for the introduction, and thanks for the opportunity to chat here. Can everyone hear me all right?
Yeah, the audio is very good, Willem.
Great. Yeah, so this was my thesis that I did for my MEd when I was training. It was on ultra low velocity knee dislocations and the vascular injury. Ironically, in vascular injuries rather than focusing on the ligamentous injury. Okay, so a knee dislocation it's a pretty rare injury, but it accounts for only 0.2% of all orthopedic injuries, but it's a true emergency due to the chance of neurovascular injury around the knee. Traditionally, knee dislocations, or commonly it's known to be high velocity and low velocity, or described according to their mechanism. High velocity being motor vehicle accidents or fall from a height, or where a great amount of force is applied to the knee. Low velocity injuries typically occur during sporting events, so soccer, any rotational pivotal rugby where the load is placed on the knee. But then there's a third category which is less well known, which is called ultra low velocity knee dislocation, and the mechanism that this is described is a knee dislocation sustained while performing activities of daily living. So you just go about your day, walking, stepping off a curb, not running or any sporting events, and the knee dislocates. There's been quite a bit written about it. Most of it is smaller studies. Morin et al. Was the first to recognize obesity as the cause for ultra low velocity knee dislocations. Azar in 2011 showed 17 patients that had knee dislocations during activities of daily living. Werner et al. And Georgiadis in 2013 and 23 patients to 18 patients. So these were, at the time when I did my thesis, this was the biggest studies available that I could find across all literature. A common theme amongst all the published things that all patients were obese. It occurs most commonly in females, and it carries a significant risk of vascular injury. Azar showed 41% incidence, Werner 28%, and Georgiadis 33% incidence. So the purpose of this study was to see if these ultra-low velocity dislocations occur in our local population at Livingston Hospital in Gqeberha, to determine the incidence of vascular injury and also the consequences and thereby creating. So this was not focused on the ligamentous, as I said, ironically. The methodology, how it was done, is we looked at all knee dislocations between June 2012 and June 2016. And then we classified them based on the mechanism of injury. So we identified all the patients that dislocated while basically going about their day. So this was a descriptive observational studies, and these were the results. So we identified 30 patients that had this injury, and at the time that was the largest kind of published amount or group of patients. 29 of them dislocated while walking, and 1 of them dislocated while putting on his shoes. I'm not even sure how that's possible. 29 of them were female, and only 1 was a male, with a BMI ranging between 35 to 53. The neurological injuries, so most common nerve that's injured is the peroneal nerve, and this occurred in about 10 of the 30 patients, so 33%. There was no tibial nerve injuries. Vascular injuries, so a CT angiogram was done on 25 of the 30 patients. The 5 that didn't have a CT angio, the reason why this occurred was 1 of them arrived with a necrotic non-viable limb, so obviously had a vascular injury, and 4 of them arrived at Livingston Hospital 24 hours after dislocation, and the decision was made to monitor them clinically. None of them had any signs of acute threatened limb. So the 10 patients that had a vascular injury, so these were the breakdowns of what kind of injury they had or what was demonstrated. So obviously the 1 was a necrotic non-viable limb. 1 patient had an intimal tear demonstrated on CT angiogram, and then 8 patients demonstrated complete cutoff on CT angiogram. And this is just a breakdown of the patients. So most of them, so the necrotic limb obviously had an above knee amputation. The patient with a CT angiogram showing an intimal tear, normal clinical examination, was treated conservatively. What was interesting were these 8 patients that had complete arterial cutoff. We know that the peripheral or the genicular branches around the knee provides poor collateral circulation in a normal, healthy person. It's not enough to sustain distal flow. And this is certainly the case for 4 of these 8 patients with complete arterial cutoff. They presented the usual way. They had absent foot pulses, they had signs of threatened limb, and they were managed surgically. And they were managed with embolectomy and a graft to bypass the occlusion. These were the interesting cases in that 4 of them, although they had complete cutoff demonstrated on a CT angio, 3 of them had no signs of threatened limb. 1 of them even had intact normal peripheral circulation, normal foot pulses. And these were all managed conservatively, the same as the 1 with an intimal tear, with observation, strict observation, anticoagulants. So this was the report that the CT angiogram showed on these patients, that there was a complete occlusion, but the flow distal to the trifurcation was intact, good trifurcation filling via genicular branches, and reconstitution of flow below the trifurcation. This was a common theme, and this is just some of the images that I've demonstrated. Not sure if you can see my mouse scrolling here, but you can see the kind of popliteal artery coming down, complete occlusion, and then distally it actually looks like normal flow distally. So these injuries behave, I mean, obviously at the time during the thesis I discussed it with the vascular guys, Prof Dube and Dr. Honeyball, about the things and why it could be like this. So kind of theorized why it could be, but they kind of behave like peripheral vascular disease with chronic insufficiency, where they develop good collateral circulation after a period of kind of slow occlusion. And this was one of the 2 theories, that there's underlying peripheral vascular disease. Well, the second theory was that because of the chronic instability around the knee, it leads to intermittent arterial occlusion. These patients, so generally patients with obesity, has a very laxity around their knee joints. And this is partly due to the ligament softening due to increased hormones around them. The fact that they're female also increases their risk for knee dislocation, just the biomechanics of how women's hips, knees are. So this was one of the theories why this could happen. So to summarize, these injuries occurs exclusively in obese patients, mostly in females. Minimal or no external force is needed to dislocate these knees. If the knees do dislocate, it carries a very high risk of vascular injury, but a vascular injury doesn't always equate to acute limb ischemia, and a normal clinical examination does not exclude a vascular injury. So for patients, obese patients with knee injuries, a high index of suspicion should be held for ultra-low for knee dislocation with concurrent vascular injury. Thank you.
Thank you very much, Willem. Very interesting study indeed. We might have one or two questions from the floor. Just a comment perhaps on wearing the shoes. They might be putting on high heel shoes, Willem. It's also a possibility. If you already have an ultra high BMI and you're trying to put on high heel shoes, it can become hazardous to you. I just want to ask Willem, any comments on the fate of the ligaments after the patients were discharged? Because like you say, most of these patients, if you think about it very clearly, if they've come in with a cutoff, it means they are habitual dislocators. So it's most likely not an isolated first event. Any comments on the fate of the ligaments once you've discharged them and all that?
Yeah, so the treatment of the ligament injuries were very difficult, and there's two, there's from an orthopedic point of view, there's options in terms of just putting them in a brace or a X-fix, leaving it all to scar up and then send on their way, or to operate on them and repair all the ligaments. And it seemed that if we were to operate on them, most of them ended up with a very stiff knee. But if you just brace them or you do an X-fix for them, they kind of maintain a level of stability in their knee, So, I mean, the study didn't look at the contralateral knee. That's maybe a good point from you. It would have been nice to look at that. But, the ligament injury certainly is difficult, But I think, that's maybe a good point to have looked at the other knees.
Yeah. No, thanks, Willem. I'm sure we got one or two questions from the floor. Anyone from the Joburg sector? And I know you published a few things on knee dislocations. Same did the Cape Town group as well. Any comments? Willem is an orthopedic surgeon who did his MMed on ultra-low velocity knee dislocations, and he's just shown us his 30-patient cohort. Any comments? Willem, we've got no takers here. I think this talk is well received, and it's obviously one of those things that the vascular and orthopedics frequently encounter. It's not a case that you always want to see. Patients generally have a BMI, and invariably most of them have poor vein conduits as well, and it kind of begs the issue of, should we be looking at better ways to revascularize them? And perhaps when we speak about the endovascular therapy in lower extremity injuries later on, maybe we might touch on that as well. If there are no further comments, I'll take this opportunity to thank Willem for your time and joining us as well. And I hope you have a good Saturday morning in Cape St. Francis Bay. Cheers, Willem.
Thank you very much. Thank you very much, Prof.
Cheers, Willem. Up next is going to be Hugh Swanepoel. He's a senior registrar at the Livingston Tertiary Hospital. He is going to be taking us through the current evidence regarding subclavian axillary stenting in trauma as well. You're free to share your slides.
All right, morning. Thank you very much, Prof. My audio is fine.
The audio is fine. We're just waiting for your slides. Are you managing there, you?
Just give me 1 second. Okay. I'm just having to present almost on 2 devices. I'm on call, so there it should start sharing now. Are you able to see now?
Yeah, it's just okay. Yeah, it looks good. Yeah. Are you at the beginning? Okay.
There we go. Is that fine?
Yeah. That looks all right. You can go ahead, please.
Okay. Thank you very much. Good morning, everyone, and thank you for the opportunity, Prof Dube, to be able to present on this topic. My topic for today is endovascular intervention for subclavian and axillary vascular trauma, or some people call it SAVI, subclavian and axillary vascular injuries, in the current era. So just an introduction, subclavian and axillary artery injuries, they are rare. That counts for about 6% of peripheral vascular trauma. But it's a high-stakes trauma, and it's definitely something that needs attention. The mechanism of injuries we look at are penetrating versus blunt, and these injuries are generally associated with a high risk of hemorrhage, limb loss or dysfunction, and mortality. And the management has been evolving over the years. You know, we've started with open, we've moved to endovascular, and now in the hybrid era, it's definitely relevant. So our focus will be on the endovascular management and the guidelines in the current era. But we have to start at the beginning. So stent graft treatment of arterial injuries has been reported since 1991. At that time, with good short and medium-term results, patients treated in these early studies were mostly hemodynamically stable and able to undergo routine angiography. And the focus was mostly on pseudoaneurysms and AV fistulas. And the stent graft procedure is favorable because it's minimally invasive with less blood loss. And in addition, it avoids surgery in anatomically challenging confined spaces with crowded critical structures. There's reduced iatrogenic brachial plexus and venous injuries. Generally, no stenotomy is required. There's less need for ICU admissions, and the procedural times and the post-procedure length of hospital stay are shorter. So to appreciate the current guidelines, I thought it's good that we first get a better understanding of the local pioneers that paved the way in endovascular management of SAVIs. So let's look at our literature and what it says. Our first paper is by Dr. Dutoy and et al., and this is from 1998 to 1999. This was a prospective study done to assess the feasibility of stent graft treatment of penetrating thoracic outlet arterial injuries. The study included 41 patients with penetrating injuries to the carotid, the subclavian, and the proximal axillary arteries. 26 patients of the 41 required urgent surgical exploration. And of the 15 patients considered for endovascular intervention, 10 patients qualified for stent graft treatment. The vessels involved, 7 of those were subclavian, 2 were carotid, and 1 was the axillary artery. 7 had AV fistulae, and 3 had pseudoaneurysms. And within these 10 patients, treatment was successful in all 10 patients with no procedure-related complications. And on a mean follow-up of 7 months, no complications were encountered. The conclusion of the study was that endovascular treatment showed promise in the 1990s or late 1990s as a treatment modality for the thoracic outlet arterial injuries, but it was noted that long-term follow-up would be required for comparison of the results of standard surgical treatment. And that's exactly what the team at Tygerberg then continued to do. So they then did a long-term follow-up, long-term results of stent graft treatment of subclavian artery injuries, and management of choice for stable patients was the question posed. This study was conducted between 1997 and 2007, so a 10-year study. All patients with penetrating subclavian artery injuries were evaluated for stent graft repair. And there was a group of 145 patients that were identified. 57 of those underwent stent graft treatment, with the remaining 88 going to open surgery. Out of the 57 patients, the pathology included false aneurysms in 42 and AV fistulae in 12 of those. Looking at the complications that occurred in the stent graft group, we'll classify those into early and to late with a 30-day cutoff. So the early complications that they saw, there was one complication from femoral artery puncture site requiring surgical repair. There was early stent thrombosis in 3 cases, and there was 1 death for the patient due to multi-organ failure. The late complications encountered, 5 patients had a more than 50% stent graft stenosis. These were fortunately managed successfully with endovascular intervention. Stent graft occlusion occurred in 3 patients, and those were managed conservatively. And 2 patients had demised from other trauma within the follow-up period. So out of this group of 57 patients, no patient experienced life or limb loss or any incapacitating symptoms by the end of the study, apart from the 2 that demised from other trauma. and there was no need for conversion to open surgery. So this study essentially reaffirmed the feasibility and safety of stent graft repair in treating stable patients with selected penetrating subclavian injuries. So following on from 2007, Dr. Naidu et al. At the department in Groote Schuur went on to do a retrospective review on stent graft repair of subclavian and axillary vascular injuries, and it was the Groote Schuur experience. This was conducted between 2008 and 2013. A retrospective chart review of all patients with trauma-related subclavian artery vascular injuries, subclavian and axillary vascular injuries, requiring stent graft repair was performed. The outcomes measured in the study included the technical success, the mortality, the amputation rate, device-related complications, and re-intervention rates early and late. 31 patients were identified, and all 31 patients sustained a penetrating injury. 21 of these were subclavian and 10 axillary artery injuries. Looking at the outcomes, so less than 30 days, there were no peri-procedural deaths. Primary technical success was found in 83.9% of patients, and there were no early procedure-related complications, re-interventions, or open conversions in the study. And then overall suboptimal results in the early review were seen in 5 patients, and these were due to endoleaks. So 1 patient had a type 1 endoleak and 4 had type 2 endoleaks. After the 30-day period, 61% of patients were available for follow-up, which I think is quite good in the state sector. Overall stent graft patency was 89.5% out of these patients that were able to be followed up. 4 patients had an occluded stent graft, and stent graft salvage was possible in 2 patients. 3 type 2 endoleaks were also seen in this late follow-up, and later interventions were performed in 5 of these patients. There was no need for conversion to an open procedure, and there was 1 late death and 1 major amputation of a stented limb in a patient who had later sustained severe soft tissue injuries during the follow-up period. And they concluded the study by saying that perioperative, early, and intermediate results suggest that stent graft repair of selected trauma-related SAVIs are relatively safe and effective. And then moving over to the most recent study done in South Africa, we look at a 10-year review of penetrating subclavian artery injuries at a major trauma center in South Africa. This was a retrospective review of all cases over a 10-year period at the Pietermaritzburg Hospital. Patients with penetrating subclavian artery injury confirmed on CT angio or intraoperatively were included, and the number there was 53 patients. Out of these 53 patients, 13 had hard signs of arterial injury, 20 had soft signs, and the remainder, 38%, actually had no signs of injury. 6 patients had an inflated Foley's catheter in situ, 5 of whom were subsequently stable enough for imaging. So this is where we're starting to see the introduction of Foley's catheter balloon tamponade and helping us to buy time to get to imaging for these patients. In the study, almost all, so 96% of patients proceeded to a CT angio on admission, with the most common findings being intimal injuries in 47% and pseudoaneurysms in 33% of cases. So going to the treatment, 22 patients, so 42% of these patients were treated with open surgery, and 8 patients were treated with endovascular stenting, and the remainder were conservatively managed with anticoagulation. There were no recorded cases of limb loss or in-hospital mortality. So the management and assessment, so what they found in the study is that the management and assessment of penetrating subclavian artery injuries has changed substantially over the years. Liberal use of CT angiography identifies lower grade intimal injuries that would have previously been missed, altering the injury profile seen in practice. Endovascular stenting still offers an attractive alternative to open surgery with lower morbidity, and the use of judicious resuscitation and techniques to control these non-compressible junctional hemorrhages reduce the proportion of patients that require emergent surgery. So just moving over to some international evidence. Will be in standing with what has been found in South Africa. They've got two studies for us, and the first was a prospective review of the Prove It registry, which was patients who were diagnosed with axillary or subclavian vessel injuries between 2014 and 2019. 23 patients with traumatic axillar subclavian injuries were included. 18 patients underwent intervention of the 23. 11 of those underwent endovascular stenting, and 7 underwent open surgical repair. Similar severity of arterial injuries between the endovascular and the open groups were appreciated, but the open group did have higher injury severity scores that were noted. The technical success for the endovascular group was 100%. The endovascular group had a lower estimated procedural blood loss, and the endovascular arterial group trended toward a shorter length of hospital stay, as well as a slightly reduced procedural time. So regardless of the injury severity score, at long-term follow-up, there was no limb losses, graft infections, or vascular complications in either the endovascular or the open group. And they concluded by saying that endovascular treatment is a viable option for axillar subclavian vessel injuries. Preliminary results demonstrate that endovascular treatment, when compared to open surgical repair, can have similar rates of technical success and long-term outcomes in patency, infection, and in vascular complications. And then the last study I would like us to allude to is the editor's choice from this journal article, which is in hospital and long-term outcomes of the repair of subclavian and axillary artery injuries. This was a study out of Sao Paulo in Brazil, a retrospective single-center study from 2009 to 2022. So obviously, data included subclavian and axillary injuries between 2009 and 2022. They had a total of 62 patients. Half of them essentially were blunt and half penetrating. And the median injury severity score was 18 there. Also to note that out of their patient population, 47% of patients had brachial plexus injuries at the time. The arterial injury was mostly occlusion in 62% of patients, and their documented median ischemic time was 12.5 hours. All patients with subclavian injuries and 13 out of 25 with axillary injuries underwent endovascular repair, and open repair was performed in the other 12 patients with axillary injuries. At hospital discharge, the amputation-free survival was 82%. The mortality was 10%, and the amputation rate was 10% for the endovascular group. After the 7-year follow-up, the stent primary patency was only 42%, but those were all managed conservatively, and no reinterventions or amputations were performed after hospital discharge. And disability was mostly related to fractures and soft tissue and brachial plexus injuries. So this study once again concluded that endovascular treatment was preferred for patients with subclavian artery injuries. Open repair was preferred for patients with penetrating distal axillary injuries. And then they also just noted the long-term complications were further related to fractures and soft tissue plus brachial plexus injuries, rather than the treatment of arterial injuries, and that a bigger focus was needed on the repair from the orthopedic side. So I know that was quite a mouthful with all of the data. So just some comparative outcomes. So where is the real advantage of endovascular repair? So we see that patients have reduced blood loss, reduced surgical site sepsis, and iatrogenic brachial plexus and venous injuries, as well as shorter procedural times and post-procedure length of stay that are shorter. The open repair indications are still there for hemodynamically unstable patients, patients with unsuitable anatomy or injury patterns, and with penetrating distal axillary injuries, selected patients. So where are we with our European guidelines? So our ESVS guidelines, the recommendation out of ESVS is that endovascular stent graft repair should be considered the preferred treatment modality for patients with subclavian artery injuries. And these are ESVS grade 2 and 3 requiring operative treatment. And I've provided, I'm not sure how well it projects, but I've provided the grading system there. So one can see the grade 2 pseudoaneurysm group and the grade 3 free hemorrhage group. So they also concluded that in appropriately selected patients, stent graft placement is associated with improved outcomes for injuries in these areas that can be challenging open exposures. And the ESVS recommends endovascular treatment for these two groups of injuries. So my conclusion, by looking at all our local data and perusing through some international data, is that endovascular repair is safe, it's effective, and it's increasingly preferred. Open repair remains vital in unstable and unsuitable patients and patients with selected axillary artery injuries. Long-term durability is still in question and does require ongoing follow-up. And the future is sitting in hybrid approaches, improved stent technology, and registry-driven evidence. Apologies. And these were my references that we used.
Thank you very much, you, for taking us through this very critical appraisal of the literature. Just to the audience that you, Swanepoel, is embarking on an MED that looks at penetrating injuries at the Livingston Tertiary Hospital. So he's done quite a lot of evidence review as well, and you'll be the right man to ask a few questions. Asha, you can go on. You can unmute yourself, Asha. I thought your hand was up there, Asha. Maybe while Asha is still unmuting herself, thanks for sharing this literature with us. Maybe any pearls regarding sort of tempering the enthusiasm with stenting? I know you're saying it looks like it's the block that's going to come through, and it doesn't look like we're going to get any randomized evidence, but any pearls regarding how we select our patients? I know you did allude to a few things. Thank you.
Hi, Prof Dube. Yeah, thank you. So I think the polls that I picked up from reading through the literature, I think alludes mostly to the complications with regards to endo leaks. So patients with prominal vertebral arteries entering subclavians and how far one should cover your stent. But I do think patient selection is vital. I know ESVS recommends even for free hemorrhage, so grade 3 injuries. But obviously that has to be taken in context of your patient's stability and your patient's reserves and the theatre time that is allowed in the state sector. So I think all of those come into play. But what it does save us is doing a stenotomy plus or minus a supraclavicular incision, and it prevents extreme blood loss, and it does help patients with less morbidities and with quicker turnaround time out of the hospital. So I definitely still think it's the way forward, as the previous pioneers have shown, and definitely a lot of promise in the field.
Okay. No, thank you. And any questions from the floor? We've got time for 1 or 2 questions. Any comments or questions from the floor regarding this? While they're still unmuting themselves, I'll say from my formative experiences while learning in Cape Town with Dr. Naidu was, I think the one thing you mustn't compromise on the stent quality. That was very important. Get the stent that will do the job for you. And unfortunately, the trauma patients are patients who, upon discharge, don't want to be found. But you must have some form of surveillance protocol, and you can't apologize regarding this. You may not find patients to follow up on this, but you must have a set up surveillance protocol. In other words, duplex ultrasound, and then intervene on demand, which is what we saw with the UCT experience, where they had a few reinterventions, and that all came from surveillance as well. Any other comments from the floor? It looks like this topic was well received as well. Thank you for sharing this with us and reminding us how valuable this is all.
Thank you very much.
Yes, any comments? Yeah, Refilwe? Sorry, I didn't see your hand there.
Yes, morning, Prof. Thank you, Hugh, for that wonderful talk and the appraisal of the literature. I just have maybe one or two questions for Hugh. So in all these papers that they looked at in patients who had endovascular stent grafts, did they mention what the antithrombotic strategy was? Because the guideline doesn't really give a guide as to how these patients must be managed post endovascular stenting. There's no consensus on how long and what must be given, whether single or dual antiplatelet therapy for these patients. So, did any of the papers mention what their strategy was?
Hi, Refilwe. Good to hear from you. So the early papers talked about their anticoagulation strategies. So that was an on-table stat dose of heparin, usually 5,000 units. And they also covered with a stat dose of cefazolin during the procedures. Unfortunately, most of the literature I looked at didn't comment on post-operative anticoagulation for these patients. And I also didn't note it in the ESVS. So yeah, unfortunately, it was a bit of a shortcoming there. It was not really mentioned.
Yeah, you're right. I think there's a paucity of evidence in that. Well, at Livingston, we just give them the good old aspirin, half a tablet daily for life. That's all we give. Other centers do it differently. Do you give a course of dual antiplatelets for a few weeks and then convert to aspirin? Nazmi, what do you do in Cape Town, Nazmi?
Hi, Becky. Can you hear me?
Yeah, I can hear you there. You're a little bit soft.
Sorry, I'm sitting in my car. I was driving. I just pulled over.
Oh, sorry.
Yeah. Similarly, we also just give aspirin a lifelong. And I also find that follow-up is notoriously difficult. I think internationally, it's a problem. I mean, I've looked at stenting outside of the subclavian and axillary arteries before, and we find that these patients, it's easy to get 30-day numbers. Anything longer than 30 days, you're going to struggle. So it makes it a bit tricky. But yeah, no, aspirin is probably something that they probably only take it for a month and then they're done with it.
No, you're right. You're right. Yeah. And any other comments from colleagues?
Yes, Prof. Just one more question.
Yes.
So, in patients who have an obvious thrombus in the subclavian or the axillary artery who are undergoing endovascular surgery, is it a myth or a reality, the concept of toothpasting the thrombus distally and actually causing possible ischemia of the upper limb when stenting these patients? Or is it just a theoretical concern?
No, you're very right with Philo. I think in my formative years, again, I think we always had a keen eye at looking at the vascular injury itself, delineate where the false aneurysm is, make sure you're not dealing with a transected vessel, because then your strategy becomes different. Over and above that, you always must identify thrombus. It will guide you in terms of how you approach and traverse the lesion as well. And where you really worry about it a lot, then you perhaps may alter your strategy by doing a more transbrachial approach and going retrograde if you're really worried about the thrombus burden, because that will be your only safe factor in going through that. But it's really not a myth, and it can really give you poor outcomes if you just gloss over it. I'm not sure if others have different ideas on this. Hi, Nazmi.
Becky, thanks. I just want to know, like, your routine approach. Say thrombus burden is kind of equivocal. Would you standard go transfemoral or transbrachial or go retrograde?
No, you're right. Where we look at it and it's minimum thrombus burden, we still come from the groin. It's much easier. It means we can put. Remember, we're using stent grafts, big sheets. I know most of the stents have recently downsized in one French, but it's still a sizable one. Brachial access means you most likely will need to do a cut down. will only add towards the brachial root where there is worrisome large thrombus burden, but minimum is from the groin. But whenever you know there's clot burden, then you really want to roadmap properly. You want to traverse clearly with your wires without touching the thrombus. I know it's theoretical, but I mean, it's just an air of caution more than anything. Any advice from the seniors? Thanks again, Hugh. It looks like your topic was well received. And also thank you to everybody for the robust engagement. The last talk is very brief. And we just saying endovascular versus open repair in lower extremity trauma. What do we have in 2026? I'll try and see if my slides will move. The only disclosure is that I'm an investigator for SciTech, which does the self-expanding stents, which are covered as well. That's my only disclosure, but I'm otherwise not biased. This is the body of literature that came out of Ohio, and they kind of looked at the endovascular appetite in multiple regions. But at the bottom end here, guided by the arrows, you can see that the lower extremity endovascular interventions almost mimic the upper extremity interventions. So it does say there is an appetite to treat patients endovascularly in lower extremity trauma as well. We probably don't do it a lot in South Africa because we are also a surgical training field. We want registrars to be able to do vascular trauma, and how better is it to do vascular trauma in the brachial and the infrainguinal regions as well. But the appetite is certainly increasing, and it does have its role. I did present a little bit on using covered stent grafts in extremity vascular trauma. That was pre-COVID years, but I think it's still relevant, nevertheless, because you frequently will be, you will frequently have to handle situations like this, where this is an old stem with a chronic false aneurysm, thankfully not an AV fistula, without a swollen limb. But once you've gone through everything, you think you've done the right thing, but look at the extent of your dissection, the morbidity that comes with that. You have to put a drain, you have to look after a wound of this sort. So it's really a balancing related issue, especially when you're looking at chronic sequelae and vascular trauma, especially if it comes with complexities of AV fistulae, amongst other things. And in a very humble series, in the FEMPOP section, we treated 31 patients, young trauma patients of average of 24 years, 9 were acute, 4 were chronic, and 1 we had an AVF relating to that. And we managed to stent them all using one stent graft, which was the Solaris stent graft from SciTech, hence my disclosure. And all I can say is I think we had 1 comeback with a stent occlusion and then required an interval bypass, but we didn't have any limb loss relating to this very modest series that we did. That was before the COVID years. So if we want to look at the current literature, either from Europe, America, or the Asia Pacific region, is this era really coming that we're going to be treating peripheral vascular trauma and endovascularly? And it was also very interesting that Prof Balapile, I don't think is on here, but when the ESVS trauma guidelines were launched, him and Damien Clark were on a podcast, and they did really go up and temper the enthusiasm of wanting to embark on endovascular all strategy for all patients that come in with lower extremity. But obviously they say this needs to be an individualized assessment of patients. So this is what we frequently encounter. You get a patient polytrauma MVA, leg is jammed in, you see the sinister fracture, leg is cold, pulseless. I mean, you cannot imagine doing endovascular work in this case where you clearly have disrupted intima. You probably want to do it open. You can shunt them and allow the friendly orthopedic guy to sort out the bone-related issues, and thereafter you can put in your vein graft there, and it will generally be with good results. But it's a road less traveled. It comes with its own worries. And we've seen this before as well. Fracture femur that's notoriously bleeding torrentially, thigh is swollen, and all it comes about is just close to the bone area, branches of the profunda have false aneurysm, and there you've got nothing to do but perhaps embark on an endovascular strategy to coil them, and coiling will give a good result, and patient can then be sorted out from a bone point of view. And we've always seen these stab buttocks, not really lower extremity, but very close, stab or gunshot buttocks with a bleed. And once in a while, if they are chronic, you think you're going in for an eye incision and drainage of an abscess, and lo and behold, you get torrential bleeding, and thankfully you can access the internal iliac artery and do coil embolization with a good result as well. We've been there. I think this debate may continue even once I'm done speaking now, putting stents across the transitional areas. You can see here, patient with trauma, AV fistula, popliteal, and popliteal artery and vein, false aneurysm. This is a nightmare. It's almost like if you do it open, it's almost like you, like Prof Pillay always says, it's almost like you are entering the Amazon jungle. You will obviously enter very easily, but leaving the place is going to be very difficult. It's going to be that, yeah. Putting a stent in, and like with the Cape Town experience, don't compromise on stent quality. Maybe try and get the best stent that is promised to give you the best outcomes for it. Again, another false aneurysm in the profunda vessel, very close to the groin. I mean, it's always very morbid getting in there, and that's how patients end up with all these nerve injuries, because it's all very, it's all quite a messy affair. And the endovascular here with coiling gives you good results. I thought I'll go backwards and look at a 5-year review of trauma in and this was in an American setup, level 1 trauma. And you can see that the algorithm at the time fits the time itself, because this is like in the early 90s, thereabouts. And you can all see that there is repair that's considered. But the only time they say consider endovascular surgery is if you have a partial or branch injury. Everything else is bypass. But we know that endovascular appetite has increased. Some people will treat even short segment occlusions, and long segment occlusions will also be managed endovascularly, but only as a hybrid approach. So this is an ever-changing field. And I thought it was very important to address what world literature says about endovascular surgery in the lower extremities. I may tail it up a little bit, but don't want to embark on the epidemiology. We know trauma happens, and it's a big issue. And if you neglect trauma, you end up with an amputation of some sort. Decision-making obviously still remains controversial, like I told you in the algorithm. But we obviously need evidence, because most of the things we see are anecdotal, and that's why it matters. And this systematic review that was done almost 2 years ago showed us that there's a few things to learn from there. If we compare 1,500 patients that underwent endo, and quite 4 times the number that had open surgery repair, and you compare issues of major amputation, fasciotomy, mortality, length of stay, having looked at all that, you will notice that they seem to suggest that if you embark on an endo strategy in low extremity trauma, your amputation rate overall is a little bit reduced, obviously, from a numbers point of view. But I think you have to temper that enthusiasm or the excitement with the fact that if you actually endo suitable, the complexity of whatever you're fixing may be quite low. So you can't really put that in that context. But that's what they found in those solid numbers. And again, same thing, your fasciotomy rates are way less if you've treated the patient endo. Does it mean it's a longer waiting time? Does it mean it's a quicker fix? But there is a strong signal that favors endo. Nerve injuries, it's a no-brainer though. I mean, if you're going to be operating on somebody, you're likely to prank nerves and all that. The only nerve sequelae that you see in endo are nerve sequelae that came with the patient on arrival with trauma. But there's no mortality benefit. I think we're looking at legs more than anything, and we're looking at lengths of stay and overall complexity, but there is no mortality benefit with whichever strategy you think of. it's a no-brainer. Patients who undergo endo will be in hospital far less. And we probably would all agree, patient comes in with a desperately ischemic limb, it's the lower extremity. If they're stable, you might CT scan them, but you end up taking them to the OR and doing some kind of repair. Intimal flaps, I think endo does it very well. I think ballooning, not so much, but you probably want to stent them. What are you going to use in trauma setup with a flap? I think you're still going to use a covered stent graft either way. And if it's a focal SFA injury, endofest will be appreciable. It's all debatable in that regard. Long section, like I told you, this is what people are doing, unfortunately. It's either you get an open repair or you get some kind of a hybrid procedure. The joints are not, people are not fearing the knee joints anymore. I think people are stenting across the knee joint as well, but I would rather emphasize this is a case-by-case decision. And you want to know what the outcomes are in most cases. I think the follow-ups are poor. And as you can see here, I'm speaking of a 6-month patency. But in general, if you do an open surgical repair and you get a good result, the result will most likely last a lifetime. We don't know anything about endovascular therapy. We can only maybe allude to a few things, but nobody goes beyond a year. And once you get to a year, the Kaplan-Meier curves tell you that there's many people that have dropped off. Yeah, I think in high injury severity scores, it's also individualized, but most of the times it becomes an open repair. So the hybrid era has come up, and what it's given to us is the fact that even long sections of SFA can be treated in a hybrid setup with both a slight open and a bit of stenting in that. And it looks like in the European and certainly in the American databases, there's more people that are being treated with a hybrid approach in lower extremity trauma. And these are the registries that I thought maybe we can support what we do. I didn't want to put up the guidelines from the ESVS regarding trauma. I think we're all aware of that, but there's a few that we see in that regard. Obviously, I didn't include the military ones because then the data becomes quite skewed. But when we go endo, I think you really worry about the longevity of the stent. You need to re-intervene. And no question has ever been answered regarding straddling across the knee joint. But I think there should not be any compromise regarding following up this patient. And unfortunately, that becomes then a surveillance burden. Yeah, well, it's not really lower extremity, but the iliacs will be good for you if you can do them endovascularly. If you've got a polytrauma and you can do part of it endovascularly, it lessens the overall time that you have the patient in theater and everything else like that. And difficult exposures, not difficult exposures, but hostile anatomy, especially where you have AV fistulas across the knee joint, then maybe endo may work for you, or an AV fistula in the mid-thigh that is chronic or a false aneurysm. I think the endo works better. You can do endo and then you can always live to fight another day. But we know that open will be required where the vessel is completely transected, where you're dealing with pediatric vascular trauma. And let's not forget, it's not every center that can treat trauma endovascularly as well. So resource is an issue as well. And we're speaking about the South African setup, where some units are only run by general surgeons. So if I may come to my last slides and conclusions, I think we all know the benefits that come with endovascular therapy. We are unsure of the longevity of the stents that we live in, but I think what the Europeans and certainly Americans are telling us is that we need to look into trying to utilize some form of a hybrid procedure to treat these. And again, I may use the term nuanced. There could be many other terms that we can use. It could be an enigma as well, but these popliteal injuries are one to debate on. But at the end of the day, you want to do something and let the patient live to fight another day. So you can use an endovascular first when appropriate. You can open when necessary, but it looks like when optimal, you can actually utilize the hybrid procedure as well. Thank you very much for your attention. I think we've gone quite fast, and we may have time for one or two questions. Any comments from the floor? And any pearls of wisdom, maybe oversight, things that we may have glossed over? I was going to ask, oh, Lucian, you there? Yeah, thanks, Lucian. You can unmute yourself.
Morning, Prof Dube. Thanks for this presentation. I think this is, well, in Durban, I think we deal with quite a bit of these vascular trauma patients. And I think it's quite interesting in terms of the different approaches that we have. I think locally, we generally go for an open first approach with these lower limb vascular trauma patients. But then we do get these select patients that come with delayed presentation, or if we have upfront with like a minimal injury or just an internal injury, and then we go for the anticoagulation route, and then it actually unmasks something. I think those can be quite tough. Generally around the knee, when they come back for their surveillance, it's not necessarily within the month or whatever the case might be. And by then they've got knee contractures and quite complex injuries. We generally will tend to stent those, and then maybe as a bridge. I'm not sure what's your experience with those patients, because they really can be quite difficult to manage. And then I think going in as well, like you said, as Prof always says, like the Amazon jungle, you can go in there, but you can't necessarily get out. Yeah, but generally locally we will go with an open first approach. And then sometimes I think if it can be, if you're anticipating like a difficult dissection, we might use like a hybrid approach where we put a balloon in first to assist with the hemostasis, and then maybe try and help us in reducing the amount of exposure that we have to do for these patients. But it's just something sort of that's in progress as well, I suppose. Thanks.
No, thanks a lot, Lucian. I echo all the sentiments, and yeah, it's much appreciated. I'm not sure, Yaki, are you around there? Yaki, your approach is in Stellenbosch. You can give us your pearls there, Yaki. Sorry.
Hi, Becky. No, I actually have no pearls to add. Maybe on the anticoagulation. I mean, in those initial series, I mean, actually, I think nothing was mostly given. And I mean, I personally now would give dual antiplatelet for a month and then long-term aspirin. But if the patients take it, but that would be anecdotal, not evidence-based at all. I just think with all these upper and lower extremity stenting, sizing is important. I think in those initial series of Prof de Tooy, I mean, he always said size discrepancy between the proximal and the distal vessel. If there's AV fistulas, associated aerodigestive injuries, thrombus burden, those were the things that they considered. But yeah, no, thanks for your presentation, Becky. It was great. And for your team for doing it at relatively short notice. And yeah, no specific comments for me further.
No, thanks, Yaki. We quite appreciate it. Any other comments from the floor? Maybe from the VIT circuit? They've been publishing prolifically as well from that side. And any comments from the VIT circuit? Pretoria, SMU? I think this is all well received, and I want to thank all of you who've managed to attend this morning. Oh, Musa, yes, Musa. You can unmute yourself, Musa. Yes, go for it.
Yes, Prof. Just one quick question. Any specific approaches, particularly to cerebral vascular trauma, particularly in the endovascular approach? Because we have a tendency to find these patients, they can dissect, have a pseudoaneurysm all the way up in the internal carotid, and some of them stroke. So are there any specific, I don't know, like coming up with a decision as to whether or not should we stent or not stent, and what would be the most feasible approach when you have these patients, because some of them stroke when we are managing.
No, thanks, and quite still a valuable question, and the considerations depend on blunt versus penetrating trauma, and they'll also depend on the extent. Is it isolated internal carotid artery encroaching onto the skull base, with which case now you need neurointerventionalists as well. Durban has a few, Cape Town has a few as well, so has Wits as well. But I think in cervical trauma in general, associated with penetrating injuries, most people, the default management will be some kind of open repair. And even those that come in with a stroke whose severity on the modified Rankin score is favorable still will also get an open repair. And we've had a few, I think we had a few publications from Steve Moyang as well, showing us that the outcomes of these young trauma patients who come in already stroked do benefit from some kind of open repair. The default is generally open repair. In the carotid area, if it's low, a little bit close to the arch, and where exposure may be difficult, selectively those patients may get a stent, very selectively. And any comments from the other colleagues? I'm just saying what we do in the Gqeberha circuit, but people can be doing it very differently in various circuits. Joburg, UCT, Stellenbosch, your comments? I think the lack of response means everybody kind of agrees with that. Thanks, Musa. Very, very important question. Any other questions from the floor? It's exactly 9 a.m. or 2 minutes after 9. Just want to thank everybody for logging in early in the morning and listening to what we had to share with you. And I hope this is a good springboard for the rest of our talks as we come up. Thank you, everybody, and have a good weekend. Keep safe and keep working hard. Thank you so much.